Systemic lupus erythematosus, SLE. What is SLE, and what does the name of the disease mean? Systemic means that the disease affects multiple organs and is not restricted to one part of the body. Erythematosus means reddening of the skin. Together with the word lupus, which is Latin for wolf, these two words reflect that the skin often is affected in SLE. The typical butterfly-shaped rash in the face is also said to resemble a wolf bite. It is one of the best-known visible symptoms of SLE. There are two important facts to remember: affects multiple organs and reddening of the skin, or skin involvement. Usually, the immune system protects the body's tissue from external pathogens. We are all dependent on a well-functioning immune system to stay healthy. Sometimes the immune cells start attacking the very tissues they're supposed to protect. When this happens, you will develop an autoimmune disease. SLE is an autoimmune disease, and essentially any tissues or organ in the body can be targeted. So what causes SLE? Nobody knows the exact cause of this disease, but there are both genetic and environmental factors involved. Let us look at the immunology behind the disease. This is a simplified model of what scientists generally think leads to SLE. Most probably the first step starts with some environmental trigger. This can be UV radiation, cigarette smoking, virus infections, use of certain medications, as well as sex hormones, particularly estrogen, or some other trigger. What is important is that some environmental triggers damage cells and causes cell death, also called apoptosis. The death of cells results in release of apoptotic bodies and nuclear antigens. At this point, the genetic components come in. Some people likely have certain genes that means they are not so good at removing these apoptotic bodies and nuclear antigens. The process of removing the apoptotic bodies and nuclear antigens is called clearance. Since the body is unable to remove the antigens, you end up with lots of nuclear antigens floating around. People affected by SLE are also likely to have genes that cause their immune cells to recognize these nuclear antigens as foreign, which initiates an immune response that causes activated B cells to produce anti-nuclear antibodies which bind to antigens and form antigen-antibody complexes. These complexes float around and deposit in various tissues, which causes inflammation. These deposits and inflammation seem to be the cause of most of the symptoms of lupus, which is a type 3 hypersensitivity reaction. Many patients also develop antibodies targeting other cells like red and white blood cells, and molecules like various phospholipids, which can mark them for phagocytosis and destruction, leading to additional symptoms. This is considered as a type 2 hypersensitivity reaction, although it isn't fully understood why some of these antibodies that target specific cells and molecules develop. The classic presentation of lupus is fever, joint pain, and a rash in a woman of childbearing age. But the actual diagnosis is difficult because it can affect a variety of people of different genders and ages, and there are also a wide range of symptoms. There are general symptoms like fever and weight loss, as well as specific symptoms depending on the organ system being affected and damaged. The newest classification criteria for SLE is from 2019. The 2019 EULAR ACR classification criteria for SLE is a collaboration between the European League Against Rheumatism and the American College of Rheumatology. The obligatory criterion is a positive ANA, either defined as positive at a titer of more than or equal to 1 in 80 on HEP2 cells, or positive with a solid phase ANA screening immunoassay with at least equivalent performance as IIF on HEP2. In addition, clinical weighted criteria grouped in 7 clinical domains are included. The concept that all criteria are only to be counted if SLE is thought to be the most likely cause of the manifestation, which means no other more likely cause exists, is central to these new EULAR ACR criteria. The 7 clinical domains are Constitutional domain, which refers to symptoms that can affect many different systems of the body, including unexplained fever for SLE. Blood, including hematologic involvement caused by autoantibodies against components in the blood, resulting in anemia, lack of red blood cells, thrombocytopenia, which is the lack of blood platelets, and leukopenia, which is affecting the white blood cells. When the leukocytes are attacked, the immune system is attacking the immune system. Brain, or neuropsychiatric, caused by autoantibodies targeting receptors in the brain, causing delirium, psychosis, or seizure. Mucocutaneous, which affects the skin. Alopecia, hair loss. Acute cutaneous lupus erythematosus, ACLE, which is the most frequent LE-specific manifestation and may occur as a butterfly rash. Discoid lupus, which is a chronic autoimmune disease affecting the skin. It gets its name from the coin-shaped lesions it produces. This condition causes a severe rash that tends to get worse when exposed to sunlight. Serosal, which is the outer membrane of an organ or tissue. If the lung is involved, it is called pleuritis, which is an inflammation of the linings around the lungs and chest cavity. With heart involvement, it can result in pericardial effusion and acute pericarditis, which is the inflammation of the lining of the heart. Musculoskeletal joint involvement with arthritis. And the last one, kidney. About 50% of patients with SLE develop renal involvement, which needs to be confirmed with abnormal levels of urine proteins. One form of nephritis is the diffuse proliferative glomerulonephritis, which is an inflammation of the glomeruli. Nephritis will always be confirmed with renal biopsy. If classified as a class 3 or 4, it carries the most weight, and in the presence of a positive anti-nuclear antibody test is enough to classify a patient with SLE. There are also 3 immunologic domains included, and these are of most importance for us. The first one is antiphospholipid antibodies, which includes anticardiolipin antibodies of IgA, IgG, or IgM isotype at medium or high titer, or positive anti-beta 2 glycoprotein 1 antibodies of IgA, IgG, or IgM isotype, or positive lupus anticoagulant. These are less specific for lupus. Because of the APS autoantibodies, SLE patients can develop antiphospholipid syndrome and therefore be more prone to develop clots and having complications like deep vein thrombosis, hepatic vein thrombosis, and stroke. These patients often end up needing lifelong anticoagulant therapy. The second immunological domain is complement proteins, and the third is the SLE-specific antibodies, which included anti-dsDNA antibodies detected in an immunoassay with demonstrated more than or equal to 90% specificity for SLE and is seen more during the state of active disease. Or anti-SM, which is antibodies against small ribonucleoproteins. If positive for anti-dsDNA or anti-SM, 6 points are given. Patients accumulating 10 or more points are classified for SLE. It is important to stress that classification criteria are not designed for diagnosis or treatment decisions. They should never be used to exclude patients who do not fully meet these criteria from receiving appropriate therapies. Lupus is characterized by periods of flare-ups and periods of remissions. Treatment is aimed to prevent flare-ups or limiting the severity when they do happen. To prevent flare-ups, some patients might need to avoid exposure to sunlight. To reduce severity of flare-ups, corticosteroids may be used to help limit the immune response, together with certain immunosuppressive drugs.